Good evening. I'd like to welcome everyone here and at home watching to tonight's forum on the November ballot questions hosted by the Grafton Shrewsbury League of Women Voters. My name is Kristen Oliveri, and I'll be the moderator for tonight's festivities. Ellen Gogan is our league president, and Paula Leva will be our timekeeper for tonight. We're going to begin tonight with an overview of question 2 and 3, and a brief presentation of the yes and no sides on those two questions. Ellen is going to read the overview on question 2.
Question 2 is titled Commission on Limiting Election Spending and Corporate Rights. This proposed law would create a citizens' commission to consider and recommend potential amendments to the United States Constitution to establish that corporations do not have the same constitutional rights as human beings, and that campaign contributions and expenditures may be regulated. Any resident of Massachusetts who is a United States citizen would be able to apply for appointment to the 15-member commission, and members would serve without compensation. The commission's first report would be due December 31st, 2019. Those supporting this question feel there is a problem with corporations and billionaires using money to buy access to politicians and influence legislation that is being considered. The Supreme Court has ruled that laws limiting political spending violate the First Amendment. This measure creates a nonpartisan, unpaid Citizens Commission to be the people's advocate for this amendment to the Constitution.
Ellen is now going to read, or give
Do you want to do the no side next? Or? You want me to do both?
Yes.
Okay, I'll do the mic. All right. All right, and question 3 is transgender anti-discrimination. The ballot question asks if voters approve of the current law passed in 2016, which prohibits discrimination on the basis of gender identity in places of public accommodation. This current law protects the rights of transgender individuals. A yes vote is to keep the current law in place. A no vote is to repeal the law. The exact wording of the question is, do you approve of a law summarized below, which was approved by the House of Representatives by a vote of 117 to 36 on July 7, 2016, and approved by the Senate by a voice vote on July 7, 2016. So that one is self-explanatory.
Missy Hollaback is going to read the no side of both of those questions.
I would like to say that the no side is not something that the League of Women Voters is supporting, nor it is my opinion. This is simply the no side that is basically in the red book that we have all read. So I will be reading now. A no vote would not create this commission. Against the controversy surrounding the Citizens United decision hinges on our cherished right to freedom of speech. In the decision, the court ruled to expand that freedom and apply it to equally to all entities and organizations, rather than just the arbitrary list of winners and losers selected by elected officials in previous campaign finance laws. This is a good thing. The First Amendment protection of our freedom of speech is one of the pillars of our democracy and should be preserved and expanded at every possible opportunity. The less government standing in the way of the exercise of that right, the stronger it is. However, even if you disagree with the Citizens United decision, an amendment to the United States Constitution is a dangerous and misguided way to go about undoing it. Please vote no on this question. This information is coming from the Massachusetts Fiscal Alliance, 18 Tremont Street, Boston, Mass, www.massfiscal.org. Again, this is not my opinion or the opinion of the League of Women Voters. I will now read the no side, the against side for question 3. A no vote would repeal this provision of the public accommodation law. Voting no repeals the bathroom bill law and prevents men from entering women's bathrooms, locker rooms, dressing rooms, and intimate spaces. The law violates the privacy and safety of women by allowing any man identifying as a woman, including convicted sex offenders, to share women's facilities. Under the law, any attempt to block a man from entering the women's locker room, dressing room, or bathroom could result in individual penalties of up to $50,000 and a year in prison. Businesses are also affected, like a female spa owner who faced a discrimination claim for declining to wax the genitals of a man identifying as a woman. No law should make women and girls feel unsafe and exploit their privacy and security. The Massachusetts legislation passed a law that goes too far, even refusing to include a provision to exclude convicted sex offenders. A no vote protects women's privacy and safety. This is a statement prepared by Debbie Dugan and the Keep Mass Safe at 400 Trade Center, Woburn, Mass, www.keepmasafe.org. Again, this is not the opinion of the League of Women Voters or of myself.
Thank you, Missy. Now we're going to start question 1. I'm going to read it first. It's kind of long, but I want to read it just because we've got both sides speaking on it. Ballot question 1. The proposed law would limit how many patients could be assigned to each registered nurse in Massachusetts hospitals and certain other healthcare facilities. The maximum number of patients per registered nurse would vary by type of unit and level of care as follows. In units with step-down intermediate care patients, 3 patients per nurse. In units with post-anesthesia care or operating patients, 1 patient under anesthesia per nurse, 2 patients post-anesthesia per nurse. In the emergency service department, 1 critical or intensive care patient per nurse, or 2 if the nurse has assessed each patient's condition is stable. 2 urgent non-stable patients per nurse, 3 urgent stable patients per nurse, or 5 non-urgent stable patients per nurse. In units with maternity patients, A, active labor patients, 1 patient per nurse. B, during birth and for up to 2 hours immediately postpartum, 1 mother per nurse and 1 baby per nurse. C, when the condition of the mother and baby are determined to be stable, 1 mother and her baby or babies per nurse. D, postpartum, 6 patients per nurse. E, intermediate care or continuing care babies, 2 babies per nurse. F, well babies, 6 babies per nurse. In units with pediatric, medical, surgical, telemetry, or observational outpatient treatment patients or any other unit, 4 patients per nurse. And in units with psychiatric or rehabilitation patients, 5 patients per nurse. The proposed law would require a covered facility to comply with the patient assessment limits without reducing its levels of nursing, service, maintenance, clerical, professional, or other staff. The proposed law would also require every covered facility to develop a written patient acuity tool for each unit to evaluate the condition of each patient. This tool would be used by nurses in deciding whether patient limits should be lower than the limits of the proposed law at any given time. The proposed law would not override any contract in effect on January 1st, 2019 that set higher patient limits. The proposed law limits would take effect after any such contract expired. The State Health Policy Commission would be required to promulgate regulations to implement the proposed law. The Commission would conduct inspections to ensure compliance with the law. Any facility receiving notice from the Commission of a complaint or violation would be required to submit a written compliance plan to the Commission. The Commission could report violations to the State Attorney General, who could file a suit to obtain a civil penalty of up to $25,000 per violation, as well as up to $25,000 for each day a violation continued after the Commission notified the covered facility of the violation. The Health Policy Commission would be required to establish a toll-free number for complaints and a website where complaints, compliance plans, and violations would appear. The proposed law would prohibit discipline or retaliation against any employee for complying with the patient assessment limits of the law. The proposed law would require every covered facility to post within each unit, patient room, and waiting area a notice explaining the patient limits and how to report violations. Each day of a facility's non-compliance with the posting requirement would be punishable by civil penalty between $250 and $2,500. The proposed law's requirements would be suspended during a state or nationally declared public health emergency. The proposed law states if any of its parts were declared invalid, the other parts would stay in effect. The proposed law would take effect on January 1st, 2019. We have two guests representing each side of question 1. On the no side, we have Dr. Teresa Rincon. Dr. Rincon is currently the Director of Clinical Operations and Innovation for Telehealth at UMass Memorial Healthcare. Teresa, want to come and have a seat at the table? After graduating with an associate's degree in nursing, Teresa started working as an ICU nurse in a large tertiary care unit in Northern California in 1997. During her early years as a nurse, she achieved advanced certification in critical care, trained new nurses, taught local classes, and worked on several research projects. Teresa was part of a team of critical care nurses to start the first telemedicine intensive care unit, the Tele-ICU, on the West Coast and the second in the nation. The purpose of the Tele-ICU was to leverage the critical care nurse and physician expertise across a large health system that spanned more than 500 miles, included very small rural critical access hospitals to small, medium community-based hospitals to large tertiary care centers. While raising 4 children with her husband of more than 30 years, Teresa has served as a staff nurse, a manager, and a director, earned an associate, a bachelor, and doctorate degrees, participated in multiple national appointments and committees within the American Association of Critical Care Nursing, the Society of Critical Care Medicine, and the American Telemedicine Association. She has been recognized with multiple awards for her service in critical care and is a nationally recognized speaker and researcher. She is a fellow in the American College of Critical Care Medicine. On the yes side, we have Katie Murphy, an RN from Brigham and Women's Hospital. Katie, will you come and sit at the table as well? Katie has been a critical care nurse for over 40 years. She is a longtime resident of Framingham and has served in many roles in Framingham, including Select Women, Finance Committee Chair, Town Meeting Member, PTO President, and has sat on many boards and commissions in Framingham. Katie has a master's degree in nursing leadership from Framingham State University and works at the Brigham and Women's Hospital as well as Metro West Medical Center. She is a member of the Board of Directors of the Mass Nurses Association and serves as the Vice Chair of the Political Action Committee. Katie has served on the National Political Action Committee and is the MNA delegate to the Labor for Single Payer campaign. I also have Lynn Flagg, who is going to be speaking. They're going to be sharing time, Lynn and Katie. Lynn is a Shrewsbury resident. She works at Shrewsbury University. She works at the university campus in the emergency department. previously worked at St. Vincent's, and she's been a nurse for 30 years, and she is also a member of the Mass Nurses Association. So she'll come to the table when Katie is done.
Oh, I also have a BSN and raised children. I have 3 grandchildren, but my battle is short.
That's important.
Each side is going to have 15 minutes for their presentation, followed by direct questions from the audience. And with those questions, you're going to have 2 minutes each to respond. So even if one question is directed towards one person, you both get to respond. Paula is going to be our timekeeper. When there's a couple minutes left in the 15 minutes, she'll give you a heads up so that you know to wrap things up. Miss Murphy, you may present first.
Thank you very much.
Let's put your speaker
Yep.
on.
Thank you very much, and thank you very much to the League for this opportunity to talk about question 1. As I would like to say, the question 1 has been endorsed by the Democratic State Party and is part of the coordinated campaign. I've been a bedside nurse for over 40 years, mostly in top 10 hospitals in the United States. I've seen safe staffing and I've seen dangerous staffing. And let me tell you, safe is better. The Patient Safety Act will limit the number of patients assigned to a nurse at any one time. What does this mean? For every patient over 4, the mortality increases by 7% per patient. Surveys of nurses have them reporting not enough time with each patient to provide quality care. Over 3/4 of nurses know of patient harm and medical error due to unsafe assignments. Over 1/3 know of a death due to poor staffing. Patients today are sicker and require more attention than in the past. And today there are no limits on the number of patients a nurse can care for at any one time. We've based our proposed staffing numbers, as you heard in the law, based on peer-reviewed research which show that patients in California, which has had this law for 14 years, receive 3 hours more care per day than Massachusetts patients, decreased readmission rates for California, which decreases hospital costs, decreased wait times in the emergency room, and better patient outcomes, to name but a few. Right now, Massachusetts has some of the worst emergency room wait times in the country. More nurses with fewer patients result in higher quality care and better flow of patients through the emergency room, as reported by the Society for Academic Emergency Medicine in 2010. The Center for Medicaid and Medicare Services, CMS, the federal agency, publishes statistics on hospital readmission rates 30 days post-discharge, a leading indicator for inadequate care, for which CMS imposes fines and penalties today. Massachusetts is the 6th worst among the 50 states, with the 6th highest less than 30-day readmission rate and the 6th highest federal fines in the United States. California, again, who has had this law in place for 14 years, has the 10th lowest readmission rates in the United States. A readmission to the same hospital for the same diagnosis in under 30 days means that something very likely went wrong in the hospital stay. Again, Massachusetts is the 6th worst. All U.S. acute care hospitals are included in this data set. Even the American Nurses Association, which is an opponent of this bill, supports our position and argues that not only is it safer for patients and nurses, but it is our ethical responsibility. In a 2016 essay for the American Nurses Association, the author, an ANA living legend, notes that adequate staffing levels reduce medical and medication errors, decrease patient complications, decrease mortality, improve patient satisfaction, reduce nurse fatigue, decrease nurse burnout, and improve nurse retention and job satisfaction, which is a fiscal bonus to the hospital industry. Now that we've established that we're all on the same page, let's talk about implementation. The Boston Globe reported in September that 9 Massachusetts hospitals already meet the guidelines presented in the Safe Patient Limits Bill. Nurses have worked together to ensure safe staffing. The Massachusetts Nurses Association believes that every patient in Massachusetts should receive safe quality care. This has been impossible to achieve in decades of negotiation and legislation filed. A little commercial, I refer you to question 2. We are an evidence-based profession, and the evidence is overwhelming that more nurses are better for patients. Question 1 is not government mandated. It is evidence-based, written by bedside nurses, the frontline caregivers who provide the care to you. Question 1 will assure that every patient receives the quality care to which he is entitled. After all, 60% of healthcare dollars are taxpayer dollars, and we believe those funds should be spent at the bedside as opposed to executive compensation, which runs into the millions. Massachusetts hospitals can afford safe patient limits. They post profits of more than $1 billion a year and stash hundreds of millions of dollars in offshore accounts. Recent studies have found that any costs incurred by hospitals to provide safer patient limits are offset by savings achieved through better care, including shorter hospital stays, lower readmissions, and fewer complications. Research released this month, October 2018, by the Joint Commission reports increased evidence of staffing and high hospital-acquired injuries, which is something you don't want to get. Don't be confused by the managers dressed in scrubs in the ads. They haven't given hands-on care in decades and have no idea how long it takes to change a complex dressing, help an 80-year-old grandmother to the bathroom, or hold a basin for a newly diagnosed cancer patient vomiting after chemotherapy. We bedside nurses do, and question 1 means more time with your nurse and better care for you. We urge a yes vote on question 1 on November 6th.
Thank you, Katie.
Thanks so much.
Wait, we're gonna have Lynn come up and speak now. She's also on the yes side. And again, it's part of the 15 minutes, so it's fair on both sides.
Okay, how much time do I have? Roughly?
About 8 minutes.
Okay, that's fine, I won't take that long. Anyway, I'm turning this on.
You just press the button.
Okay. Hi, everybody. Anyway, I work in the emergency department at University campus. I've been in the ER for about over 17 years. I only have a couple of handwritten notes. My granddaughter helped me write them, so I don't forget. Basically, I'd like to just reiterate that we in the emergency department struggle every day because we are habitually understaffed and we try to provide appropriate care. This bill would ensure the hospital to hire more nurses so that we can provide appropriate care that people are looking for. I'd like to just add to a couple of things that we've seen on the ads. One of them is nurses will get in trouble if you go over the limits. Actually, we go over the limits right now and we take critically ill patients and we struggle to give care. If we had more nurses, then people would get better care. It makes simple sense. I have stacks of things that are called unsafe staffing forms, which we tend to fill out when we have to go over limits to protect not only our patients but our licenses. So when a patient comes in having a heart attack, I might have 4 other patients. Some of them are ICU patients. I wouldn't deny care to a patient because I would be in violation of the law. You have to step outside of the law and do what you can to help somebody. So this actually has a sentence in here that says, I believe the situation described above is unsafe. I will continue to provide the best professional nursing care possible in this situation. However, I decline to accept any legal responsibility for any untoward events that may occur as a result of unsafe staffing by the hospital, agency, facility. So one of these I'll just read. It says, we're very short-staffed today. Nurses have 5 and 6 patients. The resource nurses have assignments. So when a STEMI, which is a heart attack or a trauma, comes in, we would have to abandon our assignments to give care to these patients. And people did, and we do step up to that. But the problem is, if you're habitually understaffed and you're consistently stressed to the max, these are why all these forms are filled out every day. So if the hospital was required to actually staff appropriately, they would not get fined if 10 nurses called in sick, or if there was a mass casualty, or if there was something unforeseen. The violations would be incurred if they habitually or knowingly did not staff appropriately. And this happens all the time, and there's no consequence. We file these forms. It goes into a grievance process. It goes before the hospital association, and then eventually, if we don't get satisfaction, it goes to what we call arbitration. This is months and months, and then it reaches arbitration. We might win the arbitration, but then they can still violate it. This actual law has some real teeth in it that says, let's give safe patient care, because that's what this is about. As my colleague was stating, there is a way to work together to make sure that this bill will work and it will be safe. Today, when I was in Holland today, one of the nurses from the opposition said, well, this bill really isn't really that good. It's kind of mushy inside. We've got to put it back in the oven for a little bit. Well, this might take another 6 or 8 years before it comes back on the ballot for us to actually say, let's give some safe care. Let's try to make something better for patients in general. So I'm saying that this bill is actually good. It took 100,000 signatures and a lot of hard work to get out there and say, let's make patient care first and best. And I think, one other thing too, ED wait times. So one of these actually says there were 57 patients in the waiting room one night when I was working. The reason why there were 57 patients was because there weren't enough nurses to even take another patient. So if we had more nurses in the emergency department, then it makes sense that more patients would come back and get some care. That's one of the things that you've seen on the ads, that they're saying ER wait times will be longer. That makes no common sense. The other one, holding the wall. First of all, I find this extremely obnoxious and offensive. The ambulances come in, they bring really sick patients in, and they might have to wait a minute or two. They understand the situations that when we still take care of the patients, we offer them the best care that we can. We might have to fill one of these forms out, but we don't deny anyone any care. So nobody is ever going to wait for me or another nurse to say, you know what, I already have 4 patients, I can't take another one. That's absolutely ridiculous. And as my granddaughter Avery said, she calls me Nana. Nana, when you drive down the road, she said, you know, I count all the yes signs. I'm like, oh, that's nice of you. And she said, what happens when you see so many no signs? I said, well, you know what, that just means I try harder the next time. Thank you for your time.
Thank you, Lynn. Ms. Rincon, you'll now have 15 minutes for your presentation, and Paul will remind you when you get close to the end. Oh, okay. I believe there's a presentation on the screen here. Try to turn so you can see them over here. It's not up.
We could move those posters maybe.
Is it showing up?
Actually, it should.
When I hit slideshow?
Show up in the ones that,
Is it working?
Missy, the projector turned off.
Oh, it says we need to turn the projector on. We need to return it on maybe?
It's already on.
It probably went off because we weren't using it.
Yeah.
So we need to go off and on again. Would you like me to turn this off?
You could try it out.
Yeah, here it comes on.
It was working long before you guys got here.
The yes people got to it.
Well, I can start about that. You can get it going.
Do you need a teenager?
I know, we need a teenager. I definitely need a teenager. So, I too want to thank the Women's League of Voters here and Kristen for your moderation of this, and for the audience for coming out on this evening to talk about things that are very important. And this is a really difficult measure, I think, for the voter. I mean, I think they're really struggling. They want to do the right thing. And, you know, I can say as a nurse who has been at the bedside, and guess what? I haven't forgotten what it's like to be at the bedside just because I went on to do other things in nursing. I think that's the beauty of nursing.
The beauty of nursing is that you can do so many different types of nursing. You can grow and develop. And I think Florence Nightingale, who is known as the founder of the modern nursing, is this not working? I'm going to have technical trouble all day. All right, let's turn that one on.
The devil's trying
I know.
Okay.
One of the things that she said was that we should never stop learning. We should never consider ourselves finished as a nurse. We must be learning all of our lives, because what happens in healthcare is evidence changes. And I like it that they put a quote up here, a portion of Dr. Linda Aiken's studies, and I'm going to talk about Dr. Aiken because she's an amazing researcher. And we based our experiences in California on some of Linda Aiken's early work.
Yes.
I started my career in nursing, as mentioned, in California in 1997. And in 1999, October of 1999, Gray Davis, our governor at the time, signed into law AB 394, which was mandating nurse staffing ratios in California. And we all thought this was going to be a great thing because we were having a nursing shortage. It was really all over the country, but California was really suffering. And we had extremely high nursing ratios at that time. And so we felt that, this was going to improve our outcomes, and it was going to improve our satisfaction as a nurse. And right now before you, you have a ballot proposal to mandate minimum staffing levels at all times, in all units, in all hospitals. And there's a problem with it, and I want to talk about some of the differences between the California experience and what you have before in trying to make a decision today, a very, very difficult situation. This particular ballot measure, it doesn't have any flexibility, and that's very different than the California experience. One of the things I also wanted to talk about is that this isn't just about hospitals who are saying vote no. 7 leading nursing organizations are saying vote no. The Emergency Nurses Association, the American Nurses Association, which Katie talked about, the American Academy of Medical Surgical Nurses, the Organization of Nurse Leaders, and the Infusion Nurse Society, the Massachusetts Association of College of Nursing, and the Western Massachusetts Nursing Collaborative. I think they might have some of the same concerns I have. I can't say that for sure, but I'll share with you what mine are. And then we have to look at our medical partners. Our medical partners aren't supporting this either. Our physician leaderships, our Massachusetts Medical Society, our College of Emergency Physicians, they're not supporting this. The Psychiatric Association and the Behavioral Health System, they're really worried, by the way, because they would have to come down to staffing ratios of 1 to 5 at all times, and they're worried that they might have to close over 1,000 beds. There's been a lot of work in our state about the opioid crisis, and we know it's a big deal. And we have places like a unit that was started at Harrington Hospital in Southbridge. Now they break even on that if they're lucky. It's not a big money-making adventure. And they have about 13 beds, but they don't know that they could recruit enough nurses in time by January 1st to continue to keep those beds open. And wouldn't that be a catastrophe? To have somebody who's addicted to opioids, who wants to have help, and we have to turn them away. So there's a lot of people worried about this. The Society of Respiratory Care Providers, those are the people who take care of you when you have trouble breathing. They give you breathing treatments in the hospital. They take care of you when you're on a ventilator. They also say that they oppose this, and so do the Pharmacist Association. So we see in the pediatric, I can go on and on, there's over 40. So here's my main concerns about this measure. That the lessons learned from the California experience don't seem to be considered, and that frightens me. The nurse-to-patient ratios defined in this measure are rigid, and they give the decision-making to the nurse alone. The professional judgment of other team members, like our physician partners, our respiratory care, our pharmacists, other people who help at the bedside, they don't matter. Their professional judgment does not matter. Only the staff nurse caring for that patient. The measure is confusing, it's difficult to understand. I've had so many people who are confused by this measure, and it does not allow enough time to safely and effectively implement 37 business days. And then the M&A leaves out some important new findings that Dr. Aiken has in her body of evidence, her research that she's continued to do after 2002, and I want to talk about that. But what's different about this particular question and what happened in California? Well, again, I told you that it was signed into law in 1999. Well, the people of Massachusetts are having to make the decision themselves. The second thing that's important to know is that the ratios were very high in California. I talked about that. When we look at the ratios now and we compare Massachusetts to California, Massachusetts has better ratios. That came out with the Health Policy Commission report recently. Also, in California, when Gray Davis signed it into law, the ratios were not baked into the law. So the Department of Health in the state of California spent 1.5 years working with nurses and all kinds of people throughout the state to determine what the ratios would be and how it would be rolled out, whether there would be exemptions. We have very rural hospitals that are sometimes only 50-bed hospitals, and they're in communities where you would never be able to attract enough nurses. So we had to have fair ways of establishing the ratios that made it so that we didn't close important community hospitals. Not only does this have no exemptions allowed, it actually disallows. It says on page 7 in your voter guide that the Massachusetts HPC may not, or shall not actually, promulgate any regulations to delay, to create waivers or exemptions, or to have any say-so at all about what the ratios are. That's very different than California. In California, those can be changed based on new evidence and on changes in how we provide care. So this is very rigid. It's also very reckless. Because in California, we had 5 years to implement the first wave. The first wave didn't happen until 2004. It was signed into law in 1999, but we had to wait that 1.5 years for that study to come out to tell us what's the best way to do this so that we could retain access to services and make sure we gathered up enough funding in order to pay for these nurses. But that was the first wave. We all had a second wave in 2006 and a third in 2008. So we had 8 years to do this, not 37 business days to try to recruit, hire, and train thousands of nurses. Has anybody in this room ever had to be on the hiring side? It takes a while to hire somebody. You have to put out the application. You get the people to respond to it. You interview. You do background checks. You check references. All of that has to happen. And guess what? In hospitals where collective bargaining agreements are in there, we have to wait a few weeks because we have to let all the nurses who already have seniority get to apply for those positions before we can open up to anybody else. How in the world is a hospital going to be able to hire and recruit and train? You don't want nurses with no training. I can tell you in ICU, for a new grad nurse, you're looking at about 6 to 8 weeks of training for a new grad nurse in most hospitals. And I'm talking about my experiences in California as well as what I've seen out here. And if I have an experienced nurse, maybe I can get away with 2 weeks. But if I'm taking a medical surgical nurse and then trying to have them become a critical care nurse, I've got to give them adequate training. So this is really important. There's also some confusing terms. The M&A has introduced these brand new terms, and I've never heard of them. And you've heard from my bio that I've served on national committees in critical care. I was actually a member and then the co-chair and chair for a quality and safety committee with the Society of Critical Care Medicine. It's the largest interprofessional organization in the world. And I sat on that committee with physicians, pharmacists, other nurses. I have never heard of these terms, stable urgent and unstable urgent. These are made-up terms. I even went out and polled other critical care experts, one who's the former president of the Society of Critical Care Medicine, and she had not heard of these terms. She's also a doctorate. She's very well published. I polled 2 other expert nurses, including one nurse who is the chief clinical officer of the American Association of Critical Care Nurses. She has never heard of these terms, yet we have to figure out how to implement these terms. And nurses can override the acuity score. And interestingly enough, you heard it read, hospitals are supposed to develop their own? Well, isn't that interesting? I just did a research study on looking at predictive scores and their validity. Okay, I had to become a PhD nurse to be able to interpret the validity of these measures and develop scores that could predict how many nurses patients a nurse should have. But yet we want hospitals like Little Athol Hospital to develop their own acuity scores. I'm not sure how to do that. That doesn't make a lot of sense. What else do I know? Well, if you look at this, this is from the AHRQ. This is publicly available data, and they don't have any bias on one side or the other. They just report data. And you can see here where the state of California falls in their snapshot of quality measures. They are almost at the week. There's two arrows there. There's a blue one that's most recent data. It's hard to see because the baseline, it's right on top of the baseline data. So they've made no change. And you can see over here, this is where they fall in patient safety, patient-centered care. They're over here in the orange and red, which is not good. They don't have very much in the green. So let's look at Massachusetts. Massachusetts performs better than California. And you can see here, they were in their baseline and they continue to improve. They're above their baseline. And this is, again, 2017 data. You can go find it. If you go to the AHRQ, you can find it. And you can see here where these indicators fall mostly in the green. So here we have the state of Massachusetts doing better. And in fact, when you look at their, oops, now I'm not going to be able to move my slides for some reason. Aha. So now when we look here at the AHRQ data, we can see that, I'll make this a little bigger for you, we can see that Massachusetts is number 4 in the top 10, and look where California is. This is my home state. I'm not happy to come to you and tell you this. My elderly parents are in this state, and unfortunately they're not doing as good on quality metrics. So let's go to another kind of watchdog group called the Leapfrog Group. You can go online. This is all free available data. And you can see that Massachusetts is over here at number 4. And way down here, right above Mississippi, who's probably the poorest state in the nation, is Mississippi. They rank 1 above Mississippi at 25. And there's multiple healthcare indicators that they look at for Leapfrog, including staffing. So what about the evidence? Let's talk real quick about Dr. Aiken's study. So you can see here, and this is right on the M&A's website. They have this in their footnotes, this particular study. But what they neglected to tell us was additional things that they found in their study. Sometimes you have to go down and look at that. Our results add to a growing body of research literature suggesting that improving hospital work environments may hold promise for reducing preventable deaths. Wait a minute, we're not talking about that, we're talking about staffing. Well, let's look over here. This suggests that adding more nurses without considering the work environment may be a poor investment. So let's keep going. And that was this is in 2011, the body of evidence. When you look at it here, the most important new finding in this study is that the impact of nurse staffing is contingent upon the quality of the nurse work environment and vice versa. Absent a good work environment, reducing nurse workloads by adding more nurses, a costly proposition, may have little consequence. So why aren't we talking about work environments? Why are we only talking about adding more nurses? We have shown, say Linda Aiken, we have shown better staffing, better work environments, and better educated nurses. How come we're not talking about that? Better work environments, a pretty inexpensive intervention. More BSN nurses doesn't cost any more at all. So how come we're not talking about that? Getting the value for investments in nursing requires better staffing in the context of a good nurse work environment and more educated nurses. Again, here's in critical care. This one found independent. This was independent of ratios. They found that better work environments and a higher proportion of BSN nurses improved odds of death, a risk of death. If I'm in the hospital, I want to have a lower risk of death. But this was independent of staffing ratios, so even taking ratios into account, it didn't change. And what about this? Better hospital nurse work environments had a protective effect on risk of readmissions. Better work nurse environments. This was independent of nurse staffing levels. And so what are they not telling us? They're not telling us that we also have 3 things we should be doing. We should have appropriate staffing, which means, by the way, what that means is having the right skill set and knowledge matched with the patient's needs. Better nurse and work environment, more BSN nurses, those both equal better care. This is what it's going to cost. You've seen that if you've seen some of the stuff in the literature from the HPC. And so what should we do next? This is what I think we should do next, and that's to create better working environments. I'm happy to take questions. take this one with me because that one wasn't working?
Thank you, Dr. Rincon. I just want to mention before we get on to the next portion of our forum, that the League of Women Voters does not have a stance, a yes or no stance on question 1. The League does studies when picking a side, and there just wasn't enough time to study this question. We're going to take direct questions by the audience. Each speaker is going to have 2 minutes to respond. So even if you ask a question to Ms. Murphy or Dr. Rincon, they'll each get a 2-minute response. Lynn, Flag, you may also answer any questions if Katie wants some help. Because tonight is a forum and the focus is on the ballot and not an individual candidate, attacks on either of the presenters or comments about individuals will not be tolerated. We welcome any questions on the issue at hand. Missy is going to have a microphone, and if you would like to ask a question, please state your name and where you're from, and we'll have both of the presenters answer your question. Does anybody have a question?
Mindy McKenzie from Shrewsbury. There's a lot of reference to the California situation. Was that a ballot initiative or was it a law? And if it was a ballot initiative, why is there such a disparity between what they proposed versus what Massachusetts proposed on the ballot?
So it was not a ballot measure. It was signed into law in 1999 by Gray Davis. And from that, they had the 1.5-year study which involved the Department of Health in California. And they looked at, and they worked with nurses. There was, I think, 25 nurses from various hospitals across the state who served as experts on that to develop those ratios and to develop a plan that made sense, right, that protected affordability of care, which we all should be concerned about because affordability equals access. It really does. And so we looked at, we don't want hospitals to close in California. So we wanted to do it in a safe manner, in a way in which it could be done over time, and we could take all of those things into consideration, such as unintended consequences if we did it rapidly.
Thank you. So I don't think I have to repeat the part about the ballot question, but the second part of your question was why are there the discrepancies between the California implementation and the Massachusetts implementation? Was that your?
Yeah, I mean, the 37 days versus a year. Or more.
Right, right.
It sounded like a better plan to implement it.
Well, number one, we have the California experience. So we know what it has been being implemented in California. We've seen the research that says that, that I was repeating, that more nurses per patient is safer and for patients, and that does actually contribute to a better nurse environment. So we have that research. The law will go into effect January 1st, but the regulations have to be made and developed through the Health Policy Commission. So it certainly will take effect January 1st, but the nurses will not be hired on January 2nd. And if I could just address that point, the vast majority of hospitals in Massachusetts have hired nurses part-time. They are not working full-time. They want to be working full-time. You know what student debt is coming out of college. But they are not. They are being hired as part-time workers either for 16 hours a week or maybe just as needed. So the hospitals don't have to pay them benefits. If those nurses were offered a full-time position on January 1st, these new grads from our colleges like Boston University, Boston College, UMass, highly educated, talented nurses who are not working the hours they would like today, they would be able to come on board right away.
Thank you, Mindy, for your question.
Hi, my name is Colleen Corbett. I'm from Shrewsbury. And so my question is, why are there no exceptions, like for psychiatric facilities or smaller or more rural facilities that might not be able to accommodate these rules?
That might not be able to accommodate the,
The staffing numbers, like why are there exceptions like there were, I guess, for the California law?
so right now, there are lots of regulations in place in Massachusetts. Speeding regulations, there are regulations if you took your healthy child to a daycare, there is a limit. And there's not an exception because that's for safety. So that's why we put the limits in, because we have determined through research and being at the bedside, because we are the ones in the hospital at 2 o'clock in the morning, taking care of you while you're having your heart attack, taking care of you while you're bleeding after your surgery. We have determined those limits, and they shouldn't be exceeded just for patient safety.
In the California experience, the CNA, which is the California Nurses Association, is the equivalent of the MNA here. They were not the people who determined the staffing ratios. The implementation plan and the staffing ratios were determined by the Department of Health in the state of California. And they did a very long study. They took 1.5 years. It's published if you'd like to read it. It's 122 pages long. You just need to Google AB 394 and Department of Health California and you'll find it. And in that, they laid out very methodically how this would be rolled out so that we did not put a strain on healthcare. We know that we have issues with access today all over the country. That's exactly why I went into telehealth. Because what I'm trying to do is exactly what Dr. Dixon, our CEO, it's one of his main missions. That's to improve access to care by being able to allow our expert providers to be able to consult with other providers and look at and assess patients in small hospitals. That way patients can stay in their community hospital where their network is, right? Where their support system is. We don't want to bring everybody down to Worcester. We don't. We're already crowded. We're full. You can talk to some of the nurses I see in the audience. They know how the ICU's packed. We never even have an empty bed. We're full. But yet, when we did the nurse staffing ratios in the ICU, I can tell you, I was the operations director for the tele-ICU. I had to review cases of patients that got sent down to the medical center because they didn't have enough ICU nurses to take the patient. They had open beds. They came down and sat in our emergency department for 16 to 20 hours. Some of the patients that I had to review their charts because we ended up basically closing ICU beds for periods of times when they couldn't meet the staffing ratios. And I'm telling you, that's the experience I think we'll have here if we pass this.
Thank you. Any other questions? Thanks, Colleen, for that question.
Is this thing on? Cool. Hi, I'm Eric. I'm from Grafton. So the CEO at UMass Memorial, I forget his name, he was just mentioned. Eric Dixon, thank you. My numbers are a little bit old, forgive me for that. In 2014, I know his compensation from UMass Memorial was $1.6 million, an increase of about $700,000 from the year before. That's pretty good pay rise, excuse me. Can you both talk about a little about how executive pay and maybe some administrative costs are interacting with the cost concerns that we're hearing from hospital administration with regards to this ballot measure?
Well, I can say that I don't set fair market value for wages. Fair market value for wages for any type of job is set by what fair market wages are for that particular role. And so healthcare is no different than any other industry in how we set fair market value wages. So how we determine physician wages is set by fair market value. How we determine nurse wages is set by fair market value. So I'm not an expert in economics or understanding why in America we set wages the way that we do, but that's exactly how wages are set even at the CEO level. I will say from a personal standpoint, if I was going to invest my money in a company, I want them to have the best possible leader. I wouldn't want them to skimp and say, well, we don't want to spend a lot of money on leadership, so we're only going to offer $200,000 a year or $400,000 a year, when any other large corporation that somebody would run would be making $1 million. Then I'm not going to get an experienced leader. So if I'm going to put my money on somebody with good leadership, I think I'd want to put my life in the hands of somebody who's really going to think about access to care and making sure that good, safe care occurs. And I will say that there's some amazing things that Dr. Dixon has brought in with him. One of them is idea boards. This is a way for anybody who works at UMass to find problems and try to come up with ideas to improve outcomes. And people are doing amazing work. We have hundreds of thousands of ideas that are being generated over the last couple of years. The other thing is shared governance models for our nurses, and we've now launched a standards of respect to really talk about, and all of us have to go to standards of respect training. So I think there are good things coming out of UMass under Dr. Dixon's leadership, and so I don't feel it's my place to criticize what somebody at that level makes.
Thank you for your question. As I noted, 60% of healthcare dollars are taxpayer dollars, and the CEOs at some of the major medical centers are making well into the multi-million-dollar salaries, and then we're being told that it's going to cost too much to keep you safe, and that's our argument, that money should be spent at the bedside. I mean, you saw some of the executive compensation is, upwards of several $1 million. That should be spent at the bedside, and I think that has to be looked at in the context of the HPC report, which said this would cost $800–900 million. The HPC only got the numbers from the Hospital Association, which is funding the No campaign, again, with your money. And the assumptions include raises that would already be in place in hospitals for nurses who are employed in Massachusetts now. And it also breaks out to an annual salary for me for $300,000 a year. I'm happy to take the raise, and I work a lot of overtime, but I do not make $300,000 a year. And as far as like paying for quality, I have to believe, probably the salaries in Boston and in Worcester are higher than they are in Western Massachusetts. But I know the nurses in Western Massachusetts, and I know they are excellent, and they give the highest quality care, even though they are not making what nurses are making in Boston. So saying that you have to pay for quality, I think is not something that we in the nursing profession ever find is true. We find that there is quality everywhere.
Thank you very much for your question.
My name is Greg from Holden, Massachusetts. I have a question on, there's some concerns about, like, if you read the Mass Insight report, and I don't know if they did this in the Health Policy Commission report, but there was concern about some of our community hospitals, our outlying hospitals, that this could really affect their ability to offer services. It could actually even possibly close some of those hospitals. I wondered if you guys could just elaborate on that a little bit, because they offer a lot of services that our community needs, and I'd hate to see those leave.
Sorry. Such a good point, and I have to say, no, I think it was because he had his on. I think I clicked on it when he wasn't, I think maybe that's part of it.
Okay.
They're all linked somehow. Sorry, I was like losing my, I think that I have to say the No campaign is spreading, there are a lot of scare tactics, a lot of scary information, and one thing I do say, the hospital association is spending a lot of money telling you all the scary things that might happen that are unsubstantiated, while we are telling you the scary circumstances that exist today. And so hospital executives make choices about how to spend their money every day, everywhere. And they close services and close programs, and this existed before this ballot question came on. Morton Hospital in Taunton, which is a socioeconomically challenged area, closed its maternity department, and this is not an area where people have access to vehicles, and they are supposed to go to another hospital miles and miles away. You know, and that had nothing to do with staffing. Another example is Partners, which really is not a poor hospital, closed their substance abuse program in the middle of an opioid crisis. So hospital executives make decisions every single day where to spend their money. And we always bring it back to safety. If you're in a small community hospital, you deserve to be safe having your baby. If your 2-year-old child is in the hospital, or if you're having a heart attack, you deserve the same level of safety as a hospital that might have more resources.
Well, I think in the California experience, we did not systematically improve on 6 nurse-sensitive measures. What I mean by systematically is I mean that it didn't happen everywhere. There were pockets. And so when Linda Aiken went back to research that, because she was like, wow, why did that happen, right? I mean, you're a researcher, you've done all this research that says having more nurses at the bedside is going to improve outcomes. Again, that's where she found that we have to have good work environments. Good work environments are environments where we collaborate with our other care partners. Everybody in the hospital works hard. You know, I'm a nurse, I've been at the bedside, I worked really hard. I also worked really hard when I was cleaning the rooms while I was in nursing school. Yeah, I cleaned the rooms, I was a nurse assistant / housekeeper. And that was probably the most physically difficult job I ever had in my life. So everybody, the housekeeper, the nutritional services, respiratory care providers, our pharmacists, our physicians, they work very hard. And it's a type of environment that fluctuates up and down, and you can't anticipate sometimes when those fluctuations are going to occur. But I have heard from hospitals that are concerned. They are concerned because they're going to have to come up with enough money to hire. And you know, when you think about what a nurse makes, they make more than their salary, because you have to take about 37%. See, when you work as a director, you have to work in all those calculations. So the benefits that we get in the state of Massachusetts, at least at UMass, equate to about 37% times what our annual salary is. Because that's what the hospital is kicking in for all of the benefits that we get. We don't have to pay the full price for our benefits when we work for a great health system. So yes, services will close, because guess what? It says right in the measure, January 1st, 2019, and it says the HPC cannot delay it. They cannot delay it.
Madam Moderator, could I just make a comment? I know I was instructed to ask you for your permission.
Yes, you may.
You know, could I do agree with my opponent's comment on the work environment. That is very important, and I don't know what you do in your jobs. I know in my jobs, when we don't have enough nurses to cover our patients, when we go to lunch, guess what we do? We don't go to lunch. So in a 12-hour shift, maybe about at the 11th hour, your nurse has not eaten anything, or maybe used the restroom. That is definitely work environment, because if you have 5 patients and your colleague has 5 patients, you cannot leave a nurse with 10 patients. But the hospital association, they're not saying that in their ads, but what they're really saying is that's okay.
Can I comment on that?
Yes.
But if there's 9 hospitals that have already been able to do this without having it mandated, see, the thing with mandating is that we lose the flexibility. We lose the opportunities to use professional judgment. And again, I want to remind you to read this measure closely, because it specifically says that the staff nurse taking care of the patient is the one determines what the acuity and the ratio is. What about everybody else on the team? When I was in charge in a busy 24-bed ICU unit, we had to think about patients who started crashing. One night, we had 2 patients in the unit having cardiac arrest, and then all of a sudden the code blue went out, that there was a patient on the floor. So we had to scramble. Guess what? We weren't at our safe staffing ratios at that point. But it's not like I have nurses waiting in the closet to pull them out whenever all of a sudden I have a bunch of patients that are very, very sick. There's nothing in this measure that says if there's a snowstorm and I have 20 sick calls, that nurses aren't going to call in and complain that there's not enough nurses. But if I've called everybody and nobody can get in or wants to come in, and I've had 20 sick calls, then the hospital's going to be fined $25,000 because they couldn't meet the ratios. How many nurses are they going to need to put on call in order to account for sick calls, for fluctuation in status? And again, don't forget about that new term. What is that term? Unstable urgent. So I can determine my patient's unstable urgent, and now I can only have 3 patients instead of 4 because I determine it? So I can tell you this is going to be very interesting and very difficult to operationalize, and it's going to come down to very subjective feelings about how we staff patients, and we're not going to be using objective measures, and we're not going to be including the whole team in how we make these decisions.
Thank you.
Thank you. Let's just going forward, because we do have so many questions coming. We will take rebuttals. Let's limit the rebuttals to 1 minute, just because there's so many questions.
I just have a question. You keep talking about closures and things like that. There's no law implemented now, and UMass has already closed many things. So can you speak to that?
Well, I think that Katie already hit the nail on the head. Leadership in hospitals, they have to make tough decisions. They make very difficult decisions. Even when I was a director of nursing, sometimes I had to make difficult decisions. All of a sudden, we didn't have enough money. UMass has already published it. It's been publicly available. Dr. Dixon talked about it, that we're $20 million in the red. I work with a lot of people in IS and IT with telehealth. We just laid off 17 people because we have to come up with the money. I guess Dr. Dixon could go ahead and put his whole salary in, but do you think even if he makes, I don't know what he makes, if he makes 1.6 million like this gentleman said, is that enough money to hire hundreds of nurses at UMass? Is it? So he should work for free. He should kick in his entire salary and work for free. I mean, these are really silly discussions. People shouldn't work for free, and people should get paid for what fair market value is for what they do. There is going to be closures because you're not going to be able to meet the staffing ratios. There are not a lot of nurses that have the experience and qualifications and education to do behavioral health and psychiatric care. We get a little bit, right, in nursing school. But we don't get enough to do what they do. They do an amazing job of very specialized work. We've started a lot of opioid crisis units in the state of Massachusetts. Some of those beds will have to close if they can't recruit quick enough to meet the deadline. And come on, how many nurses can you hire in 37 business days? Why didn't we partner with professional organizations as nurses? Why didn't we partner with our professional organizations and say, we've identified a problem, can you help us fix it? If you didn't trust your professional organizations, why didn't we go to the graduate schools of nursing and say, can you help us research this problem so that we can figure out a better way if we felt like we had a problem? And why aren't we also advocating for hiring more bachelor's nurses? Why is it just any nurse off the street to fill in a hole, a warm body? This is concerning. Can I comment on that?
So and we did talk about that, hospitals making decisions. The schools of nursing in Massachusetts graduate 3,000 to 3,500 nurses per year. I talked about the nurses that work part-time that would be more than willing and able to step up and serve in those in full-time positions. And again, I think we just have to keep coming back to safety. Yes, hospitals are going to have to hire more nurses. If you had a family member in one of these behavioral health units that the opposition is threatening that, hundreds and hundreds of beds are going to have to close, you want your family member getting adequate, safe care patients can be harmed in that situation. And so yes, it's going to cut into a little bit of the hospital's profit into their bottom line. Something like 3% of their operations will have to be shifted to the bedside. That's where it should be spent in healthcare.
Thank you.
Hi, my name's Lorraine from Shrewsbury. I am still kind of confused as to how this is going to eliminate the waiting times in an emergency room, which at UMass you could be there for 12 hours. I've been there many times. So if it's mandated and you don't have the manpower, so the wait's going to be, in my opinion, and I don't know enough about it, but it seems like it'll be longer. My next question is, you refer to the fact that, patient care and recidivism, meaning they leave the hospital, they come back. A lot of that, in my experience with elderly parents, has to do with Medicare. Medicare says you can be there 3 days and 3 days only, and you get released. It has nothing to do with nurse care. It has to do with a mandate that the insurance company tells you how many days for an appendix, how many days for, even to die, because my mother went through it. And she was told in comfort care that 3 days was enough. So how is that going to change? I don't see how the staffing level of nurses is going to help that.
Two very, very, very important questions. And the first one about the ED wait times. If there are more nurses in the emergency room, and I might even, rely on my colleague from the emergency room, but more nurses in the emergency room, and then more nurses up in the units, the patients will get seen in the emergency room faster, and then move up to the floor because there are nurses staffing those beds. When I'm upstairs in the floor and they want to move a patient out of the emergency room, I have a physical bed. There's a bed there. There's just not a nurse assigned to it. So yes, there has to be a nurse assigned. Can Kathy weigh in since it is the emergency room? Do you want to? I'm sorry, Lynn. Sorry.
Yes, anyways, I was speaking before. I know you've been in the emergency department. It's very difficult to be out there for hours. I want to say maybe about 4 weeks ago, we actually had, I think it was a 12 to 14-hour wait. So, and that's horrible. I know what it's like because I work in the back and I work in the front. And what I try to explain to people is, if there's more nurses, then people will come back and be cared for. Will it be ideal? Are you going to have a hallway bed? Probably. But you're a lot safer in the back of the emergency department with me taking care of you than you are sitting out in the front of the waiting room. If more nurses mean more patients come back, and as my colleague said, more nurses on the floor can get patients discharged, and then the patients will move up. And one thing I'd like to make clear too is nobody's going to incur a fine if 10 people call in sick or there's an unforeseen emergency. Then it's all hands on deck and we do the best that we can. Nobody's going to get in trouble because I have to step over my ratio. I mean, that's the problem. This is a realistic situation of how to provide safer care. This isn't about, oh my God, this nurse is going to step outside the legal ratio and be in trouble. And the hospital's not going to get fined if 10 nurses call in sick. They will get fined if they habitually leave the place understaffed, and then people complain habitually. And even then, it's subjective what the fine will be. So we need to be realistic.
Well, I think the problem here is that it doesn't say that. It doesn't say that anywhere in the ballot that hospitals can't be fined if 10 nurses call in sick. It doesn't say that. You can go through and read it. It doesn't say that. What it says is if they do not provide for safe staffing ratios, they can be fined $25,000. So what's going to happen is if a hospital has a small hospital, a community hospital has 10 nurses call in sick and they're afraid they're not going to be able to meet safe staffing ratios, they're going to put people in ambulances and they're going to send them down to Worcester just like they do today when they can't staff their ICU unit. It's already happened since we put this into place in 2016. So this is why you're going to see increased wait times because you can only process so many patients. It doesn't matter how many nurses that you have. So my other observation is if this was a patient safety question, then why are the Emergency Nurses Association telling you to vote no? The professional organization that represents nurses. They don't get any money from the hospital having a Professional Nurses Association. Why are they saying that? Why is the Emergency Physicians Association telling you to vote no? Why don't they think that this is the right solution to improve outcomes? And the last thing I want to say is for the readmission. I agree with you. There's so many other layers that cause readmission. But when you do go to the AHRQ, and I hope you go to that website and look at it, if you go to the state of California and you go through their nurse-sensitive measures, one of the ones that they are the worst in the country on is providing good education to patients when they are discharged. That can lead to readmissions.
Thank you. Hi, my name is Ellen Smith. I work at UMass. I'm an ICU nurse. I now live in Shrewsbury. So I was one of the nurses that helped implement the ICU law. I came up, I helped do the acuity tool. The law reads they have to have a plan by January 1st on how they're going to get the nurses. Just like the acuity tool when they came into the ICU, it was a plan. It took almost 3 years to develop this. It's still to this day, the other thing Teresa is saying, the other thing is UMass has no backfill. So when we're short in the ICU, I had a very sick patient last week, my resource nurse had an assignment, so I had nobody able to help me. So we fill out these things called unsafe staffing, alerting the hospital, I'm unsafe, this assignment's unsafe. The best thing they could say, do the best you can. That is not the response I want to hear if that's my loved one in there. So I just want to tell you guys, it is about safety. The hospital has been told for the last 20 years, we've been trying to make deals with these committees for the last 20 years to get safe staffing. Nobody wants to listen to us. This is why we're trying to get a law for the citizens of Massachusetts to be safe. So I urge you all to please vote yes on November 6th for your safety. It is not government mandated. It's the nurses. I'm a board of directors at Mass Nurses Association. We came up with this. Studies have shown. That's how we came up with the ratios. Studies have shown.
You need to be asking a question. Yeah. Sorry.
I was just trying to answer questions that Teresa. So I guess Teresa, so can you tell me what hospitals have actually sent us patients? Because UMass Care Connect is usually looking for patients.
I don't think it's appropriate for me to call out specific hospitals or specific patients. That would be a HIPAA violation for me to talk about that. But there have been many hospitals in our catchment area that have sent us patients. Some of them are in our own affiliated hospitals. So we have seen it in multiple situations, and we're seeing lower acuity ICU patients. But here's what I want to understand. Why didn't the M&A go to the Health Policy Commission or the Department of Health and say, we think there's a problem, we need your help? Why do we have all these professional organizations that seem to be concerned enough to tell us to vote no on this? It seems to me that we need to be, as nurses, more collaborative with our professional associations, and they can help us interpret the research. I'm a doctorate of nursing, so I can interpret research, I can conduct research. And I was able to show you multiple studies in which there were statements like the most important finding, the principal finding, and every one of them said that adding more nurses to a poor environment does not improve outcomes. It's actually an expensive proposition, and it's a bad investment. Again, why aren't we also talking about increasing the education of nurses? That's independently associated with better outcomes in mortality and failure to rescue. Why aren't we talking about those? And in readmission rates. So why aren't we talking about that as nurses? Why are we bringing to the public to vote on infusing more nurses? And why has the M&A not been able to get the support of professional organizations to support this stance?
Yes.
Thank you. So certainly the Massachusetts Nurses Association has spent 2 decades trying to implement safe staffing. in our hospitals, one at a time, one unit at a time, one hospital at a time. We have gone to the legislature for 20 years. We have filed this legislation over and over again. It has passed in the House and then not passed in the Senate. We have talked to everybody. We have met with groups. The organizations that are, and I have a flyer over there which documents the 200 organizations that are supporting us, and those tend to be the social justice, labor organizations, healthcare organizations. The people who are not supporting this, and the professional organizations, are the managers. And this was a law written by bedside nurses for the hands-on caregivers. Organizations, the emergency room organization, it was the managers. The Organization of Nurse Leaders is a wholly owned subsidiary of the Hospital Association. So it's not necessarily a professional organization, and the hospital industry is interested in the bottom line. They are interested, make no mistake, they are interested in the bottom line. The bedside nurses who wrote this are interested in making sure that you are safe and that you survive to get out of the hospital in the best shape possible. So we have been talking to our organizations for at least two decades.
This is going to be the last question. Sorry, we have a time limit here.
It's embarrassing.
No.
Well, my name's Stephen Levine. I'm from Worcester. And you keep saying many people keep coming to the Worcester hospitals. Can you tell us what many equals?
Well, we have patients transferred every day to the Worcester hospitals from outside hospitals.
How many?
I don't have the statistics in front of me, but that's what we do. We're a tertiary care center. We provide expert services that can't be provided. So I do work with the telestroke program. So
when you
patients,
tell me, I'm sorry to interrupt. You don't know how many?
there's thousands of patients who come to the medical center probably a month in this state. I would say just for the telestroke program that we provide today, we do about 5 to 6 telestroke instances a day, and about at least half of those patients, because they receive TPA, come to the medical center. So we're doing, just in that one little program alone, remember, we're a tertiary care center. We have a NICU that goes and gets babies when they're born, and they're born premature or they're having respiratory difficulties. We send nurses and respiratory therapists up to get babies and bring them back. That's what we do, and we cannot turn away ambulances. In the state of California, they do have some rules called diversion. You don't want to go on diversion, you have to fill out a bunch of paperwork to do it, but if all of a sudden my hospital is full, my emergency department is full, and I don't believe I can provide safe care because I have people lined up in the hallways and out in the waiting room, in the state of California, those hospitals can go on diversion. In the state of Massachusetts, that's not allowed. You're not allowed to go on diversion. So this will cause increased numbers of patients being admitted down to the medical center. Probably in the ICU alone, Ellen, you can talk about how many patients you admit, and a lot of them are patients that came through the ED, that came from Marlborough Hospital, Health and Alliance Hospital, Henry Haywood Hospital, Harrington Hospital, Athol Hospital. We're bringing in probably 5 intensive care unit patients a day that are coming through our emergency department from other hospitals.
So did I just hear you say 5 or 6 patients a day?
Just into the intensive care unit.
Okay, so earlier you said 1,000. If I do 6 times 30, to me that's 180. Am I missing something somewhere?
Again, I don't have all of the data in front of me. I would be happy to answer that question if I was brought into a forum in which that was what I was being prepared to ask. What I was trying to tell you, my experiences.
Well, so Steve, let her answer the question, please. And actually, it's Ms. Murphy's turn to answer the question.
Thank you. So I can't answer the question about the number of patients coming to Worcester, but I work in Boston, and we also get transfers from other hospitals, again, being a tertiary center. And very often those patients come, and it is very clear to me that, and I don't like to call out my sister and brother nurses in the state, but clearly they have been overwhelmed because the patients come with injuries or conditions which indicate that they were not getting the safe, adequate care that they should be getting. You know, some of the things that the Centers for Medicaid and Medicare will not pay for anymore, like catheter-associated injuries, pneumonias. A lot of these are indicators of the quality and amount of care being given at the bedside. And so when they come to me, I'm very well aware that, you know, out in these smaller community hospitals that people are worried about them closing, that it seems to me that the nurses are overwhelmed and understaffed. And so I can speak to the quality of patients coming in to a hospital. You know, we have very good staffing at the Brigham because we've negotiated that with management. And so I can just say that I do believe that the hospitals are showing us that they are understaffed and when the patients come to us in Boston.
Thank you. Before we wrap up, I just want to touch briefly upon...
Kristen, do you mind if I ask one question? And I also want to thank all the nurses. For the last 5 years, I've had, I don't know when I say the opportunity, but my daughter had ulcerative colitis. It was never able to heal. We went through major colon surgery. We have spent weeks and days in the hospital, in infusion rooms, in surgeries. We've had colostomy expert nurses. A couple years ago, I came down with Guillain-Barré syndrome. So we have really experienced the whole gamut of nurses and doctors. And one thing I want to say is you guys are awesome. I mean, truly amazing. It's a job that I couldn't do. But the other, I do have a question, and I have a sister that lives in California, so I visit there quite a bit, and I'm one of these data wonks. And one of the things that I'm looking at when I look at the difference between California and Massachusetts, of course, is size. But the other thing is there are a lot of uninsured and illegal immigrants in California that, according to some surveys, are adjusting the hospital numbers and care. And then also when you talked about the Medicare and situations like that. And then also in other parts of California are very rural. So are those factors kind of taken out when we're looking at the data and comparing it from Massachusetts to California? And then also Massachusetts, we're very educated, we're very, wealthy. We're going to the doctor a little bit faster than, a migrant worker in, San Diego might be. So are those factors being taken into when we look at the data?
When looking at Linda Aiken's studies, those factors were taken into consideration. So they did not include hospitals of less than 100 beds. So the data that I showed you there where we looked at whether or not adding more nurses actually improved outcomes. Again, in Linda's earlier studies, Dr. Aiken's earlier studies, we did see that. But there's a big difference. We're 20 years later. We have better staffing across the country, and specifically in different studies, it has shown that Massachusetts staffing is either equal to or even better in some studies than California is today. So we already have very good staffing. The question is this particular measure the right solution to this problem, or are we forgetting about some very important other research findings? Even Linda Aiken, who they quote, they have it right here on the poster, said that we also have to include better educated nurses and we need to include better work environments. Yet those aren't talked about in this measure. We're bringing a measure before you in which the staffing ratios are baked in. And it says right in the measure that the HPC may or shall not change those ratios. They shall not. Well, what if evidence changes? What if something's different? Why does the M&A, a labor union, want to increase the number of laborers? If they really wanted to do a well-rounded measure, they would have also included improving the environment. Everybody has a bottom line. The union has a bottom line to maintain their business. I have a bottom line in my own finances to keep my balanced books. I don't want to be in debt. We all have a bottom line, and they have a bottom line too. So if we want to make this work, I'd be happy to help them. Look at the research and create a policy like California's that takes many things into consideration in order to make sure we don't create unintended consequences. So I'm volunteering. I would work with you to create something that actually improves access to care at the same time to make sure we have appropriate staffing in the light of having good work environments and making sure we have the right education of nurses in the hospital.
I think that you ended your question was saying, you know, something about why we were doing this, and I have to bring it back. It is for safety. I just have to say, Missy, and to the audience, we actually have huge swaths in Massachusetts of incredible poverty, generational poverty, all in Boston, but all throughout the state. And these are some of the patients that certainly I see, and they don't have access to the medical centers of Worcester and Boston, but they deserve the best and highest quality care that everybody does everywhere. So while I might have good staffing at the Brigham and you might have good staffing at UMass, those small rural hospitals must also have that safe staffing. And I'm thinking particularly of a young patient that touched my heart. I work in an adult intensive care unit, but he was 20 years old from one of those rural areas who didn't have access to care that he needed. And it opened my eyes again and again to the needs of our patients. And that's what this is all about safety and quality care.
Thank you.
Again, before we wrap up, I just want to touch upon absentee voting and early voting. The deadline to apply for a ballot is noon the day before election, but allow time for the ballot to be mailed if you're not voting in person. Ballots cannot be hand carried from the town clerk's office. So you can't go there the day before and walk out with a ballot. You have to vote there. Voted ballots may be returned by mail or may be hand-delivered to the town clerk by a voter or a family member. Absentee ballots must be received in the town clerk's office by the close of polls on election day. And if you have any questions, call your city or town clerk's office. Early voting takes place October 22nd through November 2nd. In Shrewsbury, early voting is 8 a.m. to 4:30 in the afternoon, Monday through Friday at the town clerk's office. In Grafton, it's Monday, Wednesday, Thursday, and Friday, 8:30 to 4:30 at the Grafton Town Hall gym. On Tuesdays, they're open a little bit later. You can vote until 7 o'clock at night. And on Saturday, the 27th, they're open for 4 hours from 8:30 to 12:30. If you don't live in either of those towns, you can call the City Hall or your town clerk's office. Or you can go to the Secretary of State's website, and right in the middle of his page, you can click on early voting, put in your town, and it will tell you exactly where and when to vote. I would like to thank our two guest speakers tonight. We appreciate you coming, answering all the questions. We know it was a little tough at times. I'd also like to thank the audience for respectful participation. Much appreciated. And on behalf of the Grafton and Shrewsbury League of Women Voters, thank you for coming, and get out and vote.
Thank you.